Hi, I'm Megan Kruse, breast medical oncologist and director of breast medical oncology at Cleveland Clinic, and I'm joined today by my colleague.
Hi, my name is Lukas Delasos. I'm a thoracic medical oncologist at Cleveland Clinic and assistant professor of medicine at the Case Western Reserve University.
Great. So antibody drug conjugates, we're using these every day in breast cancer. And I'm really not familiar a whole lot with how we use them in other malignancies since my focus is just breast. So do you want to share a little bit about how they've impacted the treatment of lung cancers and how you think about them?
Yeah, so the major ADC that's come out in lung cancer has been in HER2, which I know you and your group have had plenty of experience with. So a few years back, it received approval for HER2 mutated non-small cell lung cancer, and also patients with non-small cell lung cancer that has HER2 overexpression with an IHC of 3+, similar to what I believe you guys use in breast. Even though nowadays I hear that you guys are using it even in low expression as well, but that's not approved yet for lung.
Okay. Yeah, it's amazing. And HER2 has really spanned the gamut now in breast cancers. We started with HER2 low. Well, we started actually with HER2 amplified breast cancers, right? And then we moved into the HER2 low space after prior chemotherapy. And then we moved into first cytotoxic with ultra low disease and HER2 low breast cancer. So it's really, increasing its footprint across essentially many of our metastatic patients, almost all of our metastatic patients. And then recently we had data looking at it in the early stage space, neoadjuvant and adjuvant treatment for HER2 positive breast cancers. So I feel like in HER2, it's just one of our go-to drugs now. It works so well. Patients feel really good on it. And I think the experience within HER2 has really made us all excited about what else is possible with antibody drug conjugates.
Yeah, I think it's really paved the way for many solid tumors, but primarily in breast. And we're following suit in lung, right, within HER2. And there's other ADCs coming out that we're pretty excited about. I'm not sure if you and breast check for c-Met amplification.
We don't at all.
We actually have approval for another drug that targets c-Met amplified non-small cell lung cancers. It's called Trastuzumab vedotin. And I have yet to have a patient on this drug yet, but the data is pretty encouraging.
Is it?
It's just another treatment option for our patients. So there's a lot of excitement, not only in the community, but also in our practice about these agents.
Yeah. So where do these fit in the treatment paradigm? Because I know compared to breast, you all have been thinking about some of the molecular data a little longer, actually, and how targeted therapies fit in versus chemotherapy. So can you walk me through how you make those decisions for your metastatic patients and where antibody drug conjugates, where you start to think about them?
Yeah, so ADCs are primarily reserved for patients with metastatic disease, advanced stages of lung cancer. We are currently, most of the excitement has been in the non-small cell lung cancer space. There are some ADCs that look pretty promising for small cell lung cancer as well. As part of a national standard for any patient that comes in with pretty much any stage of lung cancer, we're checking biomarker studies. So that includes PD-L1 expression, but also comprehensive molecular profiling of the tumor. And that really gives us an understanding of the biology of the cancer and which treatment option is best for patients. So you mentioned that we've been using targeted therapy for a while. This goes back to the early 2000s with EGFR mutated lung cancer and erlotinib and gefitinib, these first generation tyrosine kinase inhibitors that showed efficacy for those patients that had these types of mutations. Now, fast forward like 20 years later, we're seeing many more targets. ROS1, RET, ALK is the big one, right? MET exon 14. There's a whole slew of mutations that we're targeting with these small molecule inhibitors. ADCs are now moving more into the space. I mentioned in HER2, targeting HER2 mutated non-small cell lung cancer, as long as it's within the tyrosine kinase domain. I have my own patient that's on it right now, and he's responding really well.
That's great.
Toxicity is a little bit of a challenge with the nausea, the GI side effects, but otherwise he's tolerating it pretty well.
Yeah. It's funny that you bring up the toxicity piece because I think for breast, our biggest advantage, we were really convinced about the efficacy of Trastuzumab, Deruxtecan, or in HER2 very early on when the data came out. But I think what scared people, of course, was the toxicity. And I think we've had meaningful advances in how we get the drug to patients simply by becoming more comfortable with the toxicity, especially GI related. So I'm curious, have you tried different approaches for the antiemetics and what has helped?
Yeah, well, once again, I only have one patient on HER2. So usually, I mean, with platinum doublet chemotherapy, for example, I'm giving these patients Zyprexa, low dose at first, to see if that can help mitigate some of the GI side effects, primarily nausea and vomiting, obviously. Zofran as needed. Within HER2, I've been a little bit more aggressive. I'm not sure. I'd love to learn your experience with this drug. I've given my patients Decadron. All our patients get it as a pre-med, right? But I usually give them a short course of Decadron after each treatment cycle, which seems to help this one patient of mine.
Yeah, it absolutely does. I mean, I think as long as you're intentional about knowing that the nausea will happen, right? And we do our standard pre-medications, usually with 3 drug combinations, sometimes 4 drug combinations before we ever get the antibody drug conjugate into patients. But I think having the Zyprexa low dose after treatment has been really, really beneficial. And steroids too. I think it's kind of a question of what other side effects might your patient have and how do you want to take advantage of that when you're giving supportive care. So for a lot of our breast patients, we really run into not only the nausea piece, but the anxiety piece, sometimes the sleeplessness, often appetite is suppressed. So for me, that's where Zyprexa comes in. But then there are also these patients who, especially many of them that are tolerating HER2 for a very long time, they just get very fatigued. And that's where the, low dose steroids for the time right after chemotherapy can be really, really helpful. Yeah.
And that's definitely one of the biggest challenges is fatigue with like any of our therapies, right? So do you find that some of these treatment management strategies for side effects works with other ADCs that you're using?
Yeah, actually we do. So I think after our experience with T-DXd as sort of our entryway antibody drug conjugate, the incorporation of ADCs in our treatment paradigms came fast and furious, right? So now we have Trastuzumab Deruxtecan or T-DXd, we have Datopotamab Deruxtecan, and we also have Trastuzumab Govitecan. And each of these drugs have these slightly different toxicity profiles, but they do share the GI toxicities in many respects and the fatigue. And a lot of these aggressive supportive care strategies have kept patients on whatever the ADC is. But I found that the nausea piece and the fatigue piece have been fairly constant. And so the more we can prevent that, I think the better chance we have of keeping patients on, getting the meaningful benefit.
Yeah. I mean, that's what we're primarily trying to do is not just prolong their life, but also improve their quality of life, right? So I think it's, I commend you and your group for being upfront about the toxicity and addressing it as more of a prophylactic measure rather than chasing it down the road.
Yeah. And I think where sometimes providers get tripped up with these medications is they're targeted, but they're still chemotherapy, right? This is so we're so excited about having targeted medications, but if you forget that they are chemo, you'll get into trouble quickly because you still have to manage chemo side effects.
No, I'm glad you mentioned that because that's kind of how I describe it to my patients. It's a potent chemotherapy that we're giving you. It's just a reduced dose because we're using it as pretty much a homing missile.
Right.
It's tagged to this antibody that's going to a target on your tumor. But of course, I mean, that chemotherapy is getting into your bloodstream. It spills into the surrounding area, and that's going to cause side effects too. So,
Yep. Absolutely. So it's funny for those who feel like they may not be inherently familiar with antibody drug conjugates. Actually, in many ways, they already are, right? Because they're used to giving the chemotherapies that are the payloads of these drugs.
Exactly.
And so I think if you bring yourself back to how do I manage these fundamental chemotoxicities, you do well. And then there's always the unique toxicities of each drug, and we have to keep that in mind. So speaking about this in the lung space, obviously in the breast space, we worry about the lungs, but they're not our main focus.
Yep.
When T-DXd came to the lung space, how was that received with the potential lung toxicity?
Yeah, I mean, that was a big concern of ours, right? I mean, you're looking at interstitial lung disease developing in about, 15% of patients. And it seems like there might be an increased risk of that for patients with lung disease, especially if they have extensive disease in their lung, which some of our patients do. Because then if you think about it mechanistically, biologically, maybe that drug is being that homing missile, it's going more into that lung space, and that potentially increases our risk of ILD. So there's some early data that suggests maybe an increased risk, but from anecdotally, my one patient's doing okay on it right now, and I'm crossing my fingers that we don't have to run into that issue.
Yeah, and we actually see a lot of lung metastases in breast, right? So this was a concern early on, is if a patient had significant lung involvement, was that going to be a risk factor?
Yeah.
Actually, we found that it hasn't been. And
Okay,
I
that's
feel
good.
very, very comfortable with the drug in my patients with a lot of lung involvement because the drug, you pretty much guaranteed that it works for many of your patients, right? The response rates are incredibly high. And while it doesn't work for everybody, I think for those patients we're very worried about, it's a great strategy to try to cytoreduce the amount of tumor and actually have patients do better. So, we found that if patients have oxygen requirements that are related to the disease, usually we're okay. I think it concerns me when patients may have oxygen requirements for other lung comorbidities, and maybe I stop and pause. But it's actually pretty uncommon that we find that in our population. So I know you have a lot of patients coming in already on oxygen, potentially for COPD and other reasons. Would that stop you from thinking about use of T-DXd, or is it just something that you approach with caution and watch closely?
More so with caution. It wouldn't necessarily be a hard stop. If a lot of our patients have COPD, some type of restrictive lung disease, given their medical history, smoking histories and whatnot. So it gives me some pause, and maybe I harp on that a little bit more in terms of the risk of this side effect and how it could make their breathing worse. Maybe if they're on oxygen, increase their oxygen requirements. And of course, big thing I get worried about is then them ending up in the hospital. Being on a ventilator. So it's a risk that I think we need to stress to our patients, especially if we're concerned that the side effects may outweigh the benefits. But for the most part, as you mentioned, this is a strong drug. ADCs in general are making a lot of movement in not only our space, obviously your space, and for many other tumor types. So I don't think we can neglect that just because of these risks.
Right. They're too important, I think, in our treatment paradigms to just make a decision off the bat that a patient might not qualify. I think there's a lot of ways that we as oncologists get creative, right? If we really think a drug is meaningful for a patient, we sort of figure out how to make it happen in the safest way possible. And I think what you were bringing up about being proactive is really important, just like the discussion of GI toxicities. Like, we can arm our patients with the information and have them be active participants in watching for the side effects that worry us for ILD. And that's what we found with breast over time, is that as we educate it, we feel a lot more comfortable because patients are looking out for the right things. And thankfully, the ILD, it has been a reassuringly low risk, right? General rates of that are like 10 to 15%. But much of that is low-grade toxicity.
Exactly.
We're just seeing it on scans, grade 1 changes of ground glass opacities and things. And it's largely manageable, which has been, I think that is the piece of the few years of use that we've had that we can share with patients, that clinical experience, and say, we've seen this, we know how to manage it, we know how to get you through it. And I think lung will follow suit in that as you have more patients that are exposed.
Question for you, actually. So you mentioned that, obviously you have more experience with the ADCs, just given the FDA approval of some of these drugs and the years of experience using them. And you mentioned some of these newer ADCs coming into practice. Let's say you have a patient that had ILD. Even low-grade ILD, let's say, on HER2. These other ADCs, they do carry a risk of interstitial lung disease as well. So does that necessarily make you more weary, or is that an absolute contraindication for you to offer them another type of ADC? Yeah,
it's a great question, because it's the reality of our world, right? And it's not what's reflected in clinical trials at all. I think one thing that has been nice in the breast space is that we have options, right? And so we've talked about the HER2 targeted ADCs. The other big group that we have is these Trop-2 targeted ADCs. So both Trastuzumab and Datopotamab being in that space. And what's nice about that is when you have options, you can sort of play them off each other, right? You can look at the various risks of the two. I will say that even though Datopotamab's risk is lower than what we see with Trastuzumab Deruxtecan, it still does have that risk. Trastuzumab we don't really think about as being an ILD-causing medication. So usually if someone had clinically significant ILD, I would probably lean towards Trastuzumab and not enter that in. But the thing with breast cancer is that these patients do well for a really long time. And at some point, you may find yourself having to revisit the options that maybe weren't ideal at one place, but you might need to come back to them. And so I wouldn't say that it's an absolute contraindication. I think you're looking at, how have the lungs recovered? Was the patient symptomatic or not? Because, of course, if a patient is clinically symptomatic with ILD, we should avoid, further T-DXd or likely other drugs that have the risk of significant ILD. But if it's those grade 1 radiographic only changes, I think there's opportunities to try. I usually do that in combination with our colleagues from pulmonary. That because of the significant toxicities of these novel oncology drugs in general, we have kind of created this whole new field, right? Where we have specialists in other diseases working or other conditions working with us to manage toxicity. And I found that our pulmonologists can be really helpful because they're also starting to get a sense of, what is this pattern on a scan and what might that mean for a patient's recovery time, or how aggressive do we need to be with steroids or other immunosuppressants? And I think those are conversations that are in their infancy, but they're going to be really important because those management strategies are going to help us get through the real world situation. So, I think it's all a judgment call. And if a patient needs treatment, they're still doing well otherwise. As you said, it's hard to deprive them of medicines we know are active.
Yeah, exactly. I mean, you kind of hit the nail on the head there in terms of, multidisciplinary approach when approaching some of these more unique side effect profiles that we're seeing with these drugs. You mentioned that, your breast cancer patients are living longer than compared to other tumor types, especially lung, right? We don't have the luxury of that time. So a lot of patients we want for them the most effective therapies up front and not to delay treatment because we always worry that a patient there might just be a window of opportunity when they might be able to handle some of these side effects. And are we going to miss that by delaying more effective therapy, even though it might carry a higher risk of side effects? And, we don't, as opposed to breast, and granted, obviously, I have very limited exposure treating breast cancer patients outside of fellowship. In lung cancer, we don't have ADCs that we would switch to because I mentioned in HER2 is for HER2, HER2 mutated or overexpressed lung cancers. This Datopotamab, Deruxtecan that we'll talk about, Datroway. Right now it's only approved for EGFR mutated lung cancers. Now, and that's as second or third line treatment, right? But ILD actually is a risk factor, not as significant as some of these ADCs, but we see it in patients that are receiving EGFR tyrosine kinase inhibitors too. The risk is lower, and usually treatment holiday is what we offer patients, sometimes steroids, and maybe reintroduce some of these agents at a lower dose. But if they don't have a significant recovery, if they have baseline poor pulmonary function, require oxygen, especially after the event, then I get a little bit more worried. But once again, as we had already spoken about multiple times, we don't want to deprive our patients of effective therapy too.
Yeah, we run into that a little bit in breast because so much of the antibody drug conjugate use right now is in the cytotoxic space for hormone receptor positive HER2, formerly negative, now low or ultra low breast cancer. But so many of these patients, almost all of them, are going to receive CDK4/6 inhibitors in the first line metastatic space. And we don't think about it a lot, but all the CDK4/6 inhibitors have risk of pneumonitis and ILD.
Oh, wow.
And so it's rare, but it happens. And you always stop and think, it's probably more common with the TKIs that you all are using for EGFR. Our rate with CDK4/6 inhibitors is only like 2%.
Okay.
But I've seen it, and it happens. And it does make you stop and think, but I don't know. I don't think we know enough about why the pneumonitis or ILD happens with each of these different classes of drugs. Even going back to older drugs like everolimus that we still use in breast cancer, that has a risk too. But these mechanisms are probably kind of different. And I think about that too with your immunotherapy exposure. So because T-DXd is used in the HER2 mutated space or amplified space, there's not going to be a lot of crosstalk between your EGFR positive patients and the HER2 mutated patients, right? Are those kind of two biologically separate groups?
Usually biologically separate.
Okay.
But I mentioned in HER2 can be given for HER2 overexpressed, right?
Right.
And so a lot of times what we see, and what I do in clinical practice, if I have a patient, regardless of their if their tumor carries an actionable genomic alteration like EGFR, ALK, MET, whatnot, at the time of progression, I'm usually repeating a biopsy if I can, or sending off their archival tissue for HER2 testing, because you can see that patients can develop HER2 overexpression over time, or even have it at baseline, in which case I would offer them HER2 targeted therapy as well. Yeah.
So you would potentially have the choice between a couple ADCs in that space. It's not going to be a lot of your patients, but it could be.
Yeah.
And those patients have less immunotherapy exposure going in, especially if they're EGFR mutated, right?
Yeah. So some of these actionable genomic alterations, we've tested time and again. There's retrospective data, prospective data, and randomized clinical trials showing that immune checkpoint inhibitors are pretty much ineffective for patients with classical like EGFR mutated lung cancer, ALK rearranged lung cancer, RET, ROS1. KRAS, I mean, we see is the most common mutation that we find in lung cancer, and those patients still respond to immune checkpoint inhibitors. And so that's still our standard for frontline therapy is immune checkpoint inhibitor with or without chemotherapy. But for those other mutations that are really driving the growth of the lung cancer, we have much more effective targeted forms of therapy.
Yeah, that makes sense.
Yeah.
So speaking about biomarkers, because one thing we've learned as we're thinking about these Trop-2 targeted antibody drug conjugates, at least in breast, the Trop-2 level doesn't really seem to matter. Is that the same for you?
Yeah, that's what we've seen. And so Dr. Levy from Johns Hopkins actually presented some really encouraging data in the space of AI. So for some of these tropion lung studies. And so as you mentioned, the Trop-2 expression in the tumor doesn't seem to correspond with efficacy in any way. But they were looking at the cellular surface Trop-2 expression versus the cytoplasmic Trop-2 expression. And they developed this AI biomarker, pretty much looking at the ratio of that. Sorry, I can't let you know exactly what that was. It was a while since I heard his talk, but that correlated with responses to therapy. So it's an exciting area of research. I think that oncology in general is going to incorporate more of these novel biomarkers, AI driven or not, and that's going to help us with patient selection that will derive the most benefit with some of these drugs. And obviously, if we're being more selective with our patient populations, then we're exposing less people to some of the harmful side effects too. So
Right. Yeah, the Trop-2 area in breast, I think, was really interesting because we came into Trop-2 targeted ADCs after the HER2 targeted ADC, right? So we kind of were primed to say, do we need a biomarker to use these drugs? And thankfully, the answer has been no. It's made our treatment paradigms a little bit simpler since we're doing so much biomarker testing along the way. But it's led to some interesting challenges of how do we sequence ADCs, certainly. Because many of our patients are going to be candidates for both a HER2 targeted ADC, a Trop-2 targeted ADC, and there may not be a distinguishing factor between our two currently available Trop-2 targeted ADCs. So the space is crowded, and it leads to a lot of very challenging discussions because there's not a clear path forward, right? I think it's very, very patient dependent. And I have found that thankfully with a lot of my patients, they're primed to have a conversation. They've seen multiple lines of therapy. They've kind of gotten used to maybe what side effects are acceptable to them or not, or what really plays into quality of life. So we end up making a lot of the decisions very practically about what is the side effect profile, what is the schedule of infusion, and how's that going to affect into a patient's life in general. So it is an unsettling space because you feel like you probably are not making the same recommendations if you see 10 patients in the same situation. But I think it allows it to be individualized, which is nice for our patients.
It's like a double-edged sword. You have more options, but it makes it a little bit more difficult as the provider to be more firm on a recommendation.
Yeah. And do you see, for the future of ADCs in lung, is this going to be a trend? Are we going to see more agents coming in this space?
Yeah, I mean, we've already seen a lot of activity in this space. to the best of my knowledge, actually, ADCs as a concept isn't new, right? This is something that was developed decades ago, but it's only because of modern pharmacology how we're able to better target these or deliver these potent chemotherapies to more specific targets, right? So we're seeing a lot of that movement in lung, Trop-2, as we have talked about, HER2, c-Met. There's B7H3 targets nowadays coming out, both in non-small cell lung cancer and small cell lung cancer. So it's encouraging to see that we have a lot of activity in this space, and it's primarily, I see it as kind of an arms race, right?
Yeah.
Especially with some of these Trop-2 ADCs. So you mentioned Trastuzumab, Govitecan, right? So the Evoke trial in lung cancer showed that there was no benefit. So that didn't meet FDA approval. Obviously, we don't offer it to our patients. Datopotamab Deruxtecan, the initial studies showed that there was a PFS benefit, the Tropion-Lung-1 study, and that was all comers, right? So that PFS benefit was nice to see. It wasn't that significant. It didn't gain approval, right? And there wasn't much excitement in the lung community at that time. But fast forward to now, where they were being more selective with some of these post hoc pooled analyses. We see activity in patients with adenocarcinoma, but specifically EGFR mutated lung cancer.
That's so interesting.
So
it's curious because would you have expected that? Is there anything biologically that would have made you say, yeah, EGFR patients are going to be the ones?
No, not. Yeah. I mean, with my limited understanding about these drugs, and as we mentioned, Trop-2 expression doesn't seem to play a part. Biologically, I think we're still trying to figure out exactly why these tumor types respond to the therapy. They saw this positive signal. I commend the researchers for looking into this in a little bit more detail. Developing more specific clinical trials or trials directed to a specific patient population in which we're able to piece out some more of this information and figure out which patients are actually responding to this drug. So it's encouraging to see that. I mean, you have Trastuzumab, Torumotecan. I mean, I'm not sure if that's being tested in the breast space, right?
In breast, yeah.
But that's primarily in Eastern Asia, right? So that seems really encouraging too. But that's a different patient population, right? So how that shakes up to a more global population has yet to come. But it's exciting to see this, and I'm encouraged with the preliminary results.
Yeah. I think for us in breast, the space will continue to grow. I mean, as I mentioned before, with T-DXd specifically, we saw it just kind of march through different lines of therapy, different disease states, HER2 positive, HER2 low, really opened up a brand new disease state for us, right? Which may not be biologically relevant as HER2 low. It's really a disease state in which we have a targetable alteration. So, that's something that also took a little bit of time for us to wrap our heads around is what does HER2 low mean? And we're still facing that educational battle with our patients. Some of our early stage patients come in and they say, well, aren't I actually HER2 low? And it's well, biologically, we don't have to worry about that yet. Hopefully never. But, so I think that drawing that distinction is really important of what's really a biomarker, what is, a change in disease biology that we have to deal with. And then as there was so much excitement in the hormone receptor positive space, of course, the triple negative space is one of our hardest to treat areas. And we've seen activity of antibody drug conjugates there too. First, Trastuzumab in the later line setting of triple negative and hormone receptor positive. But again, the march has been forward, right? We're so excited about how it works in later line patients that we move it earlier and earlier. And so actually in the recent past, we've seen first line data for our Trop-2 targeted ADCs in metastatic triple negative, which is a big step forward for us because these patients, do very poorly. They're often very heavily pretreated before they come to their metastatic diagnosis. And I think we're wrestling a little bit there of what do we do because we have options. And the ASCENT trials were positive with Trastuzumab. TROPION-Breast02 was a trial that was positive with Datopotamab. And we wrestle with that a little bit because the patient populations are different. The results are similar, but we do see an overall survival advantage with Datopotamab that we don't see with Trastuzumab in the PD-L1 negative population. Or immunotherapy ineligible population.
Mm-hmm.
And so it does make you stop and have to make those tough choices that you thought about before. And, as people who can focus on one disease type, I think we can get into those trial details and we can dig. But I just wonder for our community oncologists who are seeing all of these diseases, like how important those trial factors are that make you choose between one drug and another drug. And it's tough. I think there's just a lot of data out there, and these sequencing questions are going to continue to be really, really challenging for us. And we're facing them in breast. We're trying to get at them. But even in clinical trials, like the post-progression therapies on trial make all the difference. And it can negate a survival advantage when you have drugs that are really powerful that come after whatever you're studying. So I think it's a tough space to take in all this data and really figure out what does it mean practically for our patients. But I think we're going to continue. In my mind, in breast, antibody drug conjugates are really completely displacing chemotherapy.
That's great.
Yeah.
Yeah.
I don't know that I ever anticipated that our first line therapy for metastatic triple negative wouldn't be a traditional cytotoxic. But here we are with ADCs, I think, really paving the way.
That's great. Yeah, I think you brought up a good point there in terms of sequencing, right? Yeah. Right now, as I mentioned, ADCs are primarily for subsequent therapy in lung cancer, but we are seeing some data, some clinical trials evaluating like Datopotamab in combination with osimertinib for EGFR mutated lung cancer. So patiently awaiting some of those results as well. So it might be moving, and some of these ADCs might be moving towards frontline therapy. We'll see what happens in the perioperative space. Patients with locally advanced disease getting chemoradiation, could you do radiation with an ADC? Could that improve outcomes? So I think these are a lot of unanswered questions that we really are need to figure out and are working towards. But going back to sequencing, that gets tricky, right? Especially with our patients where there's so much movement for EGFR mutated lung cancer, for example. I mean, for the longest time, we were just treating these patients with Tagrisso, osimertinib, which is a third generation TKI. And that was the standard, right? So it's extremely effective. Side effect profile is great. It has great intracranial activity, especially compared to some of the first generation TKIs. But over the last few years, we're seeing a lot of encouraging data coming out, improvements in progression-free survival, even more importantly, overall survival with combination therapies. So we're seeing from FLAURA2, the combination of osimertinib with platinum doublet chemotherapy as a frontline treatment option. And then from the Mariposa trial, I'm not sure if you're familiar with amivantamab, but amivantamab with their tyrosine kinase inhibitor called lazertinib, both of these trials show an improvement in survival with combination therapies. And so there's a lot of talk in our space, our community, about, okay, well, we're comfortable. A lot of oncologists, I feel like, are comfortable with a side effect profile with the addition of chemotherapy. It's not much different. Whereas the combination of targeting EGFR and MET with amivantamab, they could be a little bit more challenging, both for the physician and the patients. But if we give the chemotherapy up front with the osimertinib, what do we fall back on once they progress, right? And so that's where I think some of these ADCs might start to make more of a splash in. That's what we're seeing with Datopotamab right now is, that's considered a preferred treatment option if somebody has progressed soon after getting platinum doublet chemotherapy with osimertinib. So whether or not Datopotamab with osimertinib is going to shake up to be better
That'll
than
be the next question,
chemotherapy with osimertinib or amivantamab with lazertinib. We'll see, right? But even more so, maybe some even more novel ADCs are going to make a bigger splash, bigger waves, kind of like what we're seeing with HER2. So.
Yeah, and I think the novel ADCs are definitely going to be something that is needed in our community, right? Because right now we have a few different targets, but we largely all have topo-1 payloads. And so one of the reasons that the sequencing question is so challenging is, typically we don't use chemotherapies with overlapping mechanisms like one after another. But when you have drugs that are this active, the temptation is to sequence them one after another. And so we're still wrestling with that in breast. What is the mechanism of resistance? Can you use a Trop-2 targeted ADC after a Trop-2 targeted ADC, or a Deruxtecan payload after a Deruxtecan payload? And we don't know, right? We're just kind of figuring out as we go along. And I would say that breast has also kind of evolved in sort of the real world evidence space, because we're never going to get a randomized trial really sequencing these ADCs. There's a couple out there in breast, and we're really looking forward to them. But I think we have real decisions we have to make now, right? So we're just kind of looking to that real world evidence to give us a peek at what are other people doing and how meaningful it is to our patients. It does seem, though, like your first ADC is probably your best shot in breast cancer, and so I think it's important to the old adage still being true is use your best drugs first if you can. Because to your point, you don't know if a patient's going to be able to get the second line therapy. And I think we have real concerns about, what does ADC after ADC look like in terms of clinical efficacy? So not a situation that you all have faced quite yet, but it sounds like it's coming.
Yeah, definitely coming. And, that's a big question. Well, is it the payload that the tumor has become resistant to? Do we need to start adjusting payloads? Or is it the target, right? And you mentioned the biology changes over time. These tumors are heterogeneous, right? It's an ecological environment, right? So there's this ecological balance, not only between the tumor cells, but also the microenvironment, right? So it's becoming more and more of a challenge. And you mentioned mechanisms of resistance. I mean, we need to be mindful of this and actively search for these things. And I think a lot of clinical trials nowadays, modern studies, are doing that up front, which is great for our patients.
One other question that I was thinking about as you're talking about how the tumors change over time. In breast, we've found that if we go back and do subsequent biopsies, looking for more HER2 or looking for these targets of expression, the more we biopsy, the more we often find things that are meaningful. Has that been the experience in the thoracic world, that you would go back and look for different biomarkers over time?
Yeah, for a couple reasons. So rebiopsy, tissue biopsy is preferable. Liquid biopsy can give us meaningful information as well. And that's primarily to learn about mechanisms of resistance from a molecular standpoint, right? But now that we're seeing these ADCs that are targeting proteins on the tumor, does that change over time? I know with breast cancer, you can see differences in HER2 expression over time, correct? Right?
Absolutely.
And so I think we're still learning about that in lung because these agents are newer. We weren't really testing for that. This hasn't, for example, the panel for HER2 IHC or c-MET IHC has only come to Cleveland Clinic over the last year. Yeah, so we weren't testing for this before. It was a send-out test once these drugs started to make some movement in our space, right? So I think we're going to see more patients getting tissue biopsies, repeat tissue biopsies at progression, and not leaning so much towards liquid biopsies where the information might be a little bit more limited. And, I mentioned some of these ADCs like Dato, primarily for EGFR mutated lung cancer. Something that we always worry about with our patients with EGFR mutated lung cancer is a change in the tumor type and the histology. So you can have transformation to small cell lung cancer for in these patients that are heavily pretreated with EGFR TKIs. So if I have a patient that is on EGFR targeted therapy for a while, and all of a sudden their disease is acting much more aggressive, I'll repeat a biopsy, not just to determine next steps in management in terms of targets, but also look at the histology because it's possible that they have small cell transformation. So that's a meaningful piece of information for our patients.
Yeah, absolutely. And that, it reminds me of some of the biologic shifts we see in breast cancer too, where if you're treating a patient for early stage hormone positive, for example, and then you have a metastatic recurrence, it's so worthwhile to biopsy up front. And then, of course, we do it with progressions as well. But sometimes you lose estrogen receptor, and that would take us down a completely different paradigm where certainly some of these ADCs are going to be the best treatments for the patients right away. We wouldn't think about hormone-targeted therapy or CDK4/6 inhibitors. So very much the same. Like you're still paying attention to the clinical behavior, right? And when it doesn't make sense, you've got to get more information.
Exactly.
Yeah.
Exactly.
So thinking about Datroway being a newer drug on the block in both of our spaces, the toxicities are unique. So, and one of the ones, we talked about how with T-DXd or in HER2 that our evolution of managing lung toxicities has changed. We've gotten more comfortable. With Datroway, we're dealing with some ocular toxicities. So how does that factor into your practice, how you're counseling, how you select patients for this drug?
Yeah, it doesn't really affect patient selection very much, but I get them in to see ophthalmology just as a baseline, right? So they can establish care with them. As you mentioned, the ocular toxicity is in a significant portion of patients, right? So I'd like them to establish care with somebody, to have a baseline exam, and follow up as needed if I'm worried about some of these unique side effects. And, you mentioned, okay, it's like a different conversation with our patients about the side effect profile of Datroway versus some of our other ADCs or targeted therapies. I think about it kind of like, oh, your side effects are up here.
Yeah.
Right. So, I mean, stomatitis, mucositis, the keratitis, the ocular issues, right? So those are the big things that we worry about for these patients, let alone the ILD, which, as you mentioned, is a little bit less of a risk compared to other ADCs, but still something to keep an eye on. Yeah, I wonder, how do you deal with some of these side effects in terms of mucositis and stomatitis? Because that hasn't been so much of an issue in the lung cancer space for a long time now.
Yeah, we fortunately or unfortunately, we've had this story in breast cancer before. So I mentioned everolimus before as a drug that can cause pulmonary toxicity, but it's actually most notorious for its stomatitis risk. And when it fell out of favor, before we had as many active agents in metastatic breast cancer, we were really trying to get all of the efficacy out of it that we possibly could. And that forced us as a field to look at toxicity in a dedicated way so patients weren't giving up on the drug quickly. And one of the things that we learned about everolimus back then was the prevention of stomatitis was really meaningfully impacted by use of a steroid mouth rinse. In a very consistent way for patients, which does add to some quality of life concerns, right? But I think when you're allowing patients to be more proactive, you're saying, hey, we have a strategy to mitigate this, just like we were talking about with the antiemetics, it is more successful because it's not like you're saying, okay, this drug is going to help your cancer, but we're just going to have to deal with bad mouth sores. So I have use that in my education for patients and my planning when Datroway comes into the conversation. And we actually have our chemotherapy ordering plans in the electronic medical record where we have the steroid mouth rinse and eye drops built in. So that when a provider is ordering the ADC for a patient, those supportive care measures are immediately going to a patient's pharmacy.
That's amazing.
Yeah, and it's really helped because I think, there's so much to talk about in these conversations, right? Usually in the clinic visit with these patients, we're talking about a bad scan, we're dealing with the emotional impact of that, and then we're bringing up new drugs, potentially multiple options, and then going through side effects. So there's a lot to think about, and it's easy for these supportive care strategies to sort of slip through. And so we found that the systematic ordering of those supportive care measures has actually really helped getting patients comfortable with the drug, having them agree to take the medication or give it a try. That's been a best practice for us. And I agree, the ocular toxicities, I think, have worried us because it's a little bit outside of our own control as oncologists. At least with the stomatitis, I feel like ultimately I end up managing that. And I know what I would do. With the ocular toxicities, I feel like I can't get patients to the meaningful resolution of toxicity all the time. But we have found that having connected care with ophthalmologists and optometrists, actually. I think there are many patients who may already have an optometrist that they trust or have an existing relationship. And certainly with Datroway, you can leverage that rather than having to have a patient see an ophthalmologist and having that sort of delay getting the care started. So it's been, I would say, again, these are toxicities that worried us as we started implementing the medication use. But actually, in practicality, it hasn't been that bad.
Okay, good.
Because we have lessons from other medications we've used over time that we can extrapolate from.
Yeah, I think that's extremely helpful. It's just their past experience with the older therapies and how to manage that and apply it to novel therapies today.
Yeah.
You know, in the lung cancer space, we've kind of had the luxury of most of our therapies being very well tolerated, right? So, you know, the biggest one we worry about giving patients is subsequent therapy with Taxotere. I mean, as you probably have experience with that drug as well.
Oh, yeah.
I mean, side effect profile is awful,
Yeah.
right? So, it's funny. I was at a recent meeting where we were talking about Datroway and some of the data coming out about this drug. And one of the biggest strengths that everyone kept harping on is, well, at least it's not docetaxel. So at least it's not Taxotere, right? So even though there are these unique side effects with the drug, once again, at least it's not as, it doesn't seem to be as severe as what we're used to with more conventional chemotherapies.
Yeah, absolutely. And I think that that's been actually a big win for our patients is the lack of neuropathy with these ADCs as they stand right now with these topo-1 payloads. It's meaningful because that has been such a limiting factor for so many of our patients. And at least in the breast world, many of our patients come in with pre-existing neuropathy. And so to have medications across a large class right now that don't have that, it really does give you some freedom to work with these other toxicities. And the other thing is, you know, slight pauses in treatment can be really, really helpful. Dose reduction can be tremendously helpful when you run into these toxicities. Like, again, the old oncology standards, right? Dose reduction can be really helpful and efficacy is generally still maintained. So that's the other thing I talk with my patients about is these are really powerful drugs and sometimes the starting dose isn't going to work out for you, but that doesn't mean we give up on it, right? We can work with it and you're still going to get meaningful benefit. So that's also a very reassuring story.
Another toxicity with this drug is alopecia, correct? So I mean, more than half of the patients, right?
Yeah.
I remember as a fellow learning about like cold caps and primarily in the breast cancer space, right?
Yeah.
Do you have any experience using cold caps for these patients receiving Datroway? Does it help?
Yeah. I haven't used it so much with Datroway yet. There have been a couple of patients who have been interested in using it with some of the other antibody drug conjugates that we have available. And it's been a challenging situation. I think the half-life of these drugs is much longer than conventional chemotherapy, right? So there's a very limited amount of data out there in the breast world that maybe cold capping is not as successful. But, you know, I think if you have a patient who's highly motivated to do it, we've certainly realized over time that cold capping is very safe for our patients, right? And so if it's something that would be meaningful for a patient to say, I want to give it a try, you can, if it doesn't work out, that's fine. You can stop it. But if somebody's on the fence and said, you know, I'd rather take like in the breast cancer world, sometimes the alopecia is a serious consideration between an ADC and something like conventional capecitabine chemotherapy. And if that's really the decision-making factor, then we can try it, right? There's no harm. It just, I think we have to set expectations that it just may not be as successful as standard old taxane chemotherapy where it works really, really well. But I think this is the important part of this whole discussion we're having is that it's flexible, right? We're lucky to have options in these spaces that we never had them before. And we can work with the toxicities with patients in a way that hopefully allows them to get the benefit of these newer drugs.
I agree. So, you know, we were talking about in HER2 and GI prophylaxis, primarily fighting against nausea and vomiting. Do you find that like a current, any regimen of medications is more effective for your patient population and any drawbacks to those?
Yeah, that's a great question. So when HER2 first came to our practice, it was listed as more of a moderately emetogenic regimen. And so I think for the most part, we were having patients use pretty typical 3-drug regimens, sometimes even 2-drug regimens, largely steroid-based and like Zofran-based for our patients. What we found with HER2 over time is if you're not cautious about the nausea, it can really be a problem. And there's actually been subsequent discussion of it being a more highly emetogenic regimen. And whenever we have a drug that moves into that category, we really want to be more aggressive. So my standard practice has been to use a 3-drug prophylactic IV regimen before the patient ever gets the drug, and then to add in my 4th drug, which is typically Zyprexa at a low dose before bed for my patients. medications. And it's funny, I normally think about that 4-drug regimen being something that I do in the few days that follow chemotherapy. But actually, many patients really love the added benefits of getting that 4th drug. I think we're really getting multiple cancer-related symptom control when we bring in Zyprexa. And so many of my patients opt to just continue on with that medication throughout the whole cycle in between doses because they really do feel better. And as I've talked to patients about it, so many of them would rather prevent nausea than reactively responding to it. And that's where I would be as a patient.
Same here.
So I think that has really become our standard. And much like we do with other supportive medicines in the ADC space, we have that as part of our standard order set. So when I order in HER2 for patients, I am getting my 3 IV medications for nausea beforehand already in there and the prescription for patients to receive the Zyprexa when they go home. And as I said, I usually, even though we'll say take it for 3 days after the medication is administered, I actually usually give patients enough pills to let them take it every night because it typically ends up being so meaningful.
Yeah, I think we follow suit in the lung cancer space. We want to stay ahead of nausea and vomiting. That's something you and the patient, especially the patient, don't want to be chasing, right? So a lot of times, especially with Zyprexa, low dose it can be very effective. I mentioned before that usually I start at 2.5 milligrams, and it's tolerable. The other side effects that patients can develop from it are minimal, if not even apparent, right? So again, I'd like to stay on top of nausea and vomiting.
Me too.
And prevent it rather than chase it.
Absolutely. And I think from another education standpoint, I've learned that it's really important to call out that Zyprexa is an antipsychotic medication because I've had a couple patients in the early days where I may have said, oh, it's for nausea and not really said it. And they get to the pharmacy and they're like, what is she thinking about me? Why is she prescribing me an antipsychotic?
Antipsychotic. Yeah, I get that all the time.
So I do actually include that in my standard chemotherapy education or ADC education that we're using this for a specific purpose, right? There's no hidden agenda here, but we have found that nausea management is really much, much better when we bring it in.
And another side effect that we run into with ADCs, any type of therapy, immune therapy, targeted therapy, is fatigue, right? And that can be extremely difficult to manage for patients, and it can hinder their quality of life more so than any other side effect, right? There's no straight answer about how to manage that, right?
I wish there was.
I'd love to hear your input. What I've noticed sometimes, though, because we were just talking about nausea and vomiting, a lot of times when I piece things together with my patients, they always tell me I feel run down, fatigued, but then they won't really address the nausea as much, right?
Yeah.
And I feel like if they're not vomiting, then they're not paying so much attention to that. And maybe that can be driving the fatigue more than anything.
Right.
So it's something that I think accompanies, all these side effects can accompany one another. And maybe sometimes if we can really address the nausea, prevent it, we can really mitigate the fatigue.
Yeah.
But I'd love to hear your insight on that as well.
Yeah, I agree. I think with fatigue management, this is where I really pull out my internal medicine hat because I found that it's so multifactorial, right? I think there is no doubt that for patients who are on prolonged cytotoxic therapy, whether it's conventional chemotherapy or antibody drug conjugate, that there is a fatigue element that is progressive. If it is that mostly progressive fatigue that we're really convinced is the drug related, right? Like we've looked for coexisting sleep disorders and we've fixed mood disorders and we've minimized medications that might be making them tired. I'm really convinced that it is our cancer therapies. I've really found that dose reduction is the most helpful thing. And this is where I find myself really trying to assure patients that when we look at follow-up results of these studies, even patients who had dose reduction in a purposeful way, right? Because we know their toxicity was significant, that they still benefit from the drug. So like we were talking about earlier, this is another education point that you really have to walk patients through. I also wonder if many of my patients minimize the degree of their fatigue because they don't want me to cut back on the chemotherapy dose. And so this is open dialogue, right? And by the time we're recommending these medications to patients, I think we probably have an established relationship that we're talking through all of these things. But I feel like that is probably the most meaningful thing I do is say, we're treating your cancer so you can be here, you can be living, but I want you living that life. And if your fatigue is
Exactly.
a hindrance to you living your life, then we've got to do something about it. Unfortunately, it's been hard because I feel like many of our patients are looking for a quick fix in that fatigue, and it's usually not that kind of
Yeah, as you mentioned, it's
toxicity.
multifactorial, and there could be a psychosomatic component to that too. A lot of times, especially for my patients with advanced stages of lung cancer, even if they're relatively asymptomatic, even after starting therapies, I'm referring them to our palliative med group.
Absolutely.
I think they play an integral part in terms of the patient care, and they can help assess the fatigue, help work on the fatigue, but maybe even touch on some of these social aspects that might be contributing. This is a life-changing diagnosis. It impacts not only their personal lives, their professional lives, and that can be that emotional burden that these patients are carrying can also be massive fatigued.
Yeah, absolutely. I found myself doing the same, actually. I know there's like good data out of the lung cancer world, actually, originally, that early incorporation of PalMed involvement helps patients live longer.
Yeah.
And I think there really is something to that. And, I have not been brave enough on my own to think about things like stimulants for fatigue.
Yeah, same.
Occasionally, our palliative medicine physicians, I think, do think about stimulants. And we've had some success, but I think you have to be very cautious about what patients you recommend for what drugs. And honestly, treating mood disorders and treating like all of the complicated emotions that go around this cancer diagnosis actually helps a lot with fatigue, I feel like. So yeah, going back to, using medicines that have multiple purposes, right? So if we can get a medicine that is good for mood and for pain, that's a great solution. And it often helps patients with their fatigue element. While we're in the toxicity realm, so going back to ILD, we are very fortunate to have a lot of resources, right? Where we practice, we can pick up the phone and call a friend in the pulmonary group and say, hey, I'm worried about the scan. What do you think? When you're seeing patients that may be managed in the community setting or you're getting referrals from other places, do you have thoughts on how they should work with those concerns about interstitial lung disease and how to interpret scans?
Yeah, that can become extremely difficult in areas that have less resources. There's no straightforward answer, right? Early pulmonary intervention for ILD, early intervention from our palliative medicine colleagues for some of these cancer-related but also treatment-related side effects is integral. If our patients out in the community don't have easy access to those resources, well, we have the luxury at Cleveland Clinic and large academic centers, hospital systems in a more populated area. You have the luxury of these different subspecialties, right? A lot of the community oncologists can send their patients for that type of referral at some of these centers, and they don't necessarily need to be seen frequently by those disease groups, right? But they can at least address some of the issues. It could be more of a second opinion with less frequent follow-up than a patient would have with their community oncologist, but that consultation can go a long way.
It can.
And, a lot. I know for patients that I receive referrals for second opinions, I'm having my notes faxed with my number to these physicians. A lot of times I send emails to these physicians, call them directly and provide my information because I understand that it's not easy for some of these patients to get to us, right?
No, it's a team sport. I think we all do better when you have multiple brains thinking about these situations.
Yeah, so I don't think that should discourage oncologists in the community that aren't that close to any of these academic centers from sending their patients as a referral, not just for medical oncologists, but also pulmonary, PalMed, all these other disease groups in which it could be extremely helpful for these patients just to be seen.
Yeah, absolutely. And I think there's no harm if you're worried about a significant toxicity in trying to start therapy for it, right? We know that where most of these patients, if they do have clinically meaningful ILD development, early action with steroids can be very, very meaningful. And that's actually been something tough in the breast cancer world because we haven't had a ton of drugs that cause this. We were sort of late to the game with immunotherapies and immune checkpoint inhibitor toxicity and early intervention with steroids for that.
Yeah.
But I feel like so many of our community oncologists probably have that prior exposure.
They do, yeah.
And know that early intervention with steroids is meaningful. And I would say that applying that list of management approaches to antibody drug conjugate toxicity actually wouldn't be a bad thing to do if you're in a situation where you're really worried, but you don't have your pulmonologist you can reach out to.
Yeah, nobody would ever fault somebody, right? So if you have the patient's best interest in mind, early intervention is key, and referral for a second opinion is also key, right? But that can wait, right? As long as you're trying to manage the toxicity, there's national guidelines easily accessible for anybody practicing out in the community. So that's integral again to their care.
Yep. So I think, high index of suspicion when it comes to ILD, frequent reassessment with CT scans, which can be tough, right? It can be tough to get frequent imaging when you're in a community setting as well. Even in an academic setting, I find it hard to get a CT scan any sooner than 8 weeks or 12 weeks for my patients between scans. But you can if you're really concerned. And then early initiation of treatment makes a big difference.
Yeah. And if it's difficult for patients to get to these more academic or tertiary care centers, I mean, there's forums online. There's resources that patients can use to reach out. Not only the patients, but also providers can reach out to leading experts and ask for their opinion.
Yeah.
So sometimes that can go a long way.
Yeah, absolutely. Lean on that collective knowledge, right? You're not on an island.
Yeah, it's becoming more of a global practice, right?
Absolutely. Yeah. And those best practices are where I get a lot of my tips and tricks from, right?
Yeah.
It's just from the experiences of others and it can really make a difference for the lives of our patients.
Agreed, yeah.
Thank you for our audience for listening in today on our conversation. And thank you, Dr. Delasos, for being here today. I certainly learned a lot.
I learned more from you. From fellowship to staff, you're always teaching me.
It's an evolving journey. Yeah. And I think it's that way for all of us. So thanks again for your attention to our audience. We look forward to seeing you next time.